Yep. So I will talk about some tips and tricks for early control of high intraocular pressure after Baerveldt tube implant with one case as the illustration. This is an old 80-year-old Caucasian female patient has a past medical history of both eye pseudoexfoliation glaucoma. She had her right eye operated in 2013 with cataract surgery. And in the left eye, she had a failed trap long time ago and without any anti-metabolite application. And then she had an uneventful cataract surgery. Then the left eye was fixed with suture, IOL, and pars plana vitrectomy in the early this year by Dr. Vicky Lu. And when coming to us, she was on medical treatment with Zalatan, Truzop, Comigan, and Diamox, 250 milligram 3 times a day. And the pressure before the surgery in her left eye was 44. The vision was poor, 620 and pinhole 636. In the OCT, we can see a normal nerve fiber layer thickness in the right eye and a superior and inferior thinning of the nerve fiber layer in her left eye. And on 31st of August, she had her left eye operated with a Baerveldt tube implant and a scleral patch graft. And surprisingly, the first day after surgery, her pressure went up to 60. And after 2 taps, the pressure gradually down to 40 and stay on that with a maximum medical treatment. On the day 3 after the surgery, we tried to perform a laser suture lysis, but it was unsuccessful after several attempts because she had a very tight orbit. So we decided to perform the 3rd AC tap and the pressure down to 10. And the next day, the pressure up to 28. So we discharged on Simbrinza Ganfort and Diamox 4 tablets. Coming back to the clinic after 1 week, the pressure was creeping up back to 44 on maximum medical treatment. So we decided to remove the 3O nylon stenting. And after the removal, the pressure down to 2, and she developed some high FEMA. And in the same week, so about 10 days after the surgery, she had an accident. So her head hit the bed frame. And after this head trauma, the vision down to counting finger, the pressure was 12, the AC became shallow, and she had high FEMA. And on the B scan, we found a vitreous hemorrhage, choroidal detachment, and the retina was flat. So the initial treatment for her second admission was atropine 1% twice a day. We kept her on Masidex every 2 hours, Closic 4 times a day. And about 1 or 2 days after the second admission, there was some fibrin membrane in her anterior chamber. So we started the prednisone 25 milligram once a day in the morning with some PPI. And then we consulted the VR team. And according to VR's opinion, we should just observe the patient, and she might have a chance to recover because for the blood dissolving, because her left eye is vitrectomized, was vitrectomized. 4 days after the trauma, so in the second week after the surgery, the vision was counting finger 1 meter. The pressure was 8, and the AC formed, and she still had some high FEMA. with the very thick fibrin membrane. So at that time, we thought of an intracameral injection of TPA. 6 days after the trauma, so in the 3rd week after the surgery, the vision was hand movement, the pressure was still 8, and the VR team repeated the B scan and found a significant kissing choroid, but luckily the retina was still flat, and they advised us to hold off the TPA because the disappearance of fibrin membrane might cause a recurrent hypotony and worsen the suprachoroidal hemorrhage. And they were planning for choroidal drainage 7 to 10 days after the trauma. And about 10 days after the trauma, the pressure was 12 and the vision was light perception. The fibrin was much improving, and we could get a better view of the intraocular lens and the anterior vitreous. So at the moment, the VR team still waiting for the choroidal drainage. So I will talk about a few main points about some tips and tricks to early control the high intraocular pressure, about my experience with the Sydney Eye Hospital approach for this kind of situation, and some real-world literature review. From my perspective, I realized that we have a couple of options when dealing with the patient with high pressure after tube implant. We can use medical treatment. We can use single or double stenting. We can use intraoperative fenestration, WICK placement, laser suture lysis, or even we remove the 3O nylon stent. So for patient without any nylon stenting and no fenestration, so we use 7O or 8O vicro ligation suture, and we expect an early autolysis after 4 to 6 weeks. Then we should only use medical treatment. For most of the cases with 3O nylon stenting and with or without WICK placement and fenestration, we can use medical treatment with intraoperative and at a higher level, with the releasable WICK suture, we can remove the placement when the pressure is still uncontrolled, and we can even perform the needling under the subscleral patch graft space to break the scarring and try to engage the flow through the fenestration. And finally, if the above options don't work, then we can think about laser suture lysis, plus or minus stent removal for the medically uncontrolled pressure. This is a study on the efficacy and the safety of the 10O nylon, 10O monofilament fenestration. So they concluded that the use of a single monofilament 10O suture to stent a fenestration close to the occlusive ligation is effective in controlling intraocular in the early post-operative period. And this is the way they did the WICK, the fenestration, and then they leave the suture there. There was another study. They compare between fenestration and WICK placement, and they found that the use of 2 nylon wicks with fenestration can significantly lower the pressure and reduce the burden during waiting for the dissolution of the ligation suture. And this is the way they perform the wick placement and leave the suture there. In another study, they also compare wick placement and fenestration, and they found out that the wick placement can safely lower intraocular pressure and reduce the medication burden, but didn't offer additional utility to fenestration alone. So fenestration or fenestration with wick placement could all help reducing the pressure and the medication burden during the early period after the surgery. And in this study, they use a super sharp blade to create the venting slit, and then they leave the suture there. Another approach is single or double stenting. So in this study, retrospective study, they divided the subjects into two groups: a single stent or double stent. So single stent is 5-0 polypropylene, or double stent was 5-0 or 6-0, and then they found that both groups have the controlled decrease in intraocular pressure. And for the double stenting technique, it offers a sooner or greater post-operative reduction in intraocular pressure and a quite good safety profile. And this is the way they did the single or double stenting. And the last question is, what else we can do if the pressure keeps escalating even when we remove the 3-0 nylon stenting? I think this is the end of my talk. Thank you.